in and will be filtering in, but we have quite a bit of material to get through today and people to speak even after Dr. Pham, so we'll go ahead and get started. But today we have Dr. Joe Pham, who's one of our third years, and he's presenting a case from the inpatient medicine department who's sponsoring it. All right, thanks. In and will be filtering in, but we have quite a bit of material to get through today and people to speak even after Dr. Pham, so we'll go ahead and get started. But today we have Dr. Joe Pham, who's one of our third years, and he's presenting a case from the inpatient medicine department who's sponsoring it. All right, thanks.
I'm Joseph Pham, and welcome to my CPC. So it is what the blue note says. And I had mixed feeling about the blue note before. On the one hand, the reason why you get the blue note in the beginning is because you probably didn't do something right. But on the other hand, it does help you get better, and I like it. I appreciate it. So I do have a long presentation. If I talk a little bit fast, there is a reason. And this case is very interesting. The deeper I get into the case, the more strange the case becomes. And even now, I still don't know if the case is rare condition, very rare, or never been reported before. Or I could have the diagnosis wrong completely. So you don't want to miss the ending. So Dr. Moran gave me a list of objectives, and I promised her that I would stick with the objectives, so we're going to start. This is a case of 69 years old African-American woman who has 6-month history of dyspnea on exertion and lower extremity edemas. There is progressively worse with PMD and orthopnea. She was given diuretics with Lasix with no improvement. She had multiple hospital admissions for decompensated heart failures. Her last hospital admission was about 1 week ago, and it was for similar symptoms. Her past medical history includes breast cancer on the left side in 1981 and returned on the right side in 2005. And she also had hypertension, hyperlipidemia, and vertigo with GERD. She had an autoimmune disorder that I was not given the diagnosis of, for which she was given dexamethasone about 6 weeks before the current admission. For surgical history, she did have left mastectomy in 1981 and the right side in 2005. I was not told of any chemotherapy that the patient received for the breast cancer. For her medication, breakdown to different group. For heart medication, she had aspirin, metoprolol, nifedipine, Lasix, clonidine, and Zocor. For GI, she takes Prilosec, Reglan, and she also takes supplement include potassium, thiamine, CoQ10, vitamin D, and calcium, and multivitamin. The other medications she takes, Flonase, dexamethasone, and Ambien. Family history include her parents were healthy, lived into their 90s, a brother with a stroke in his 60s, and his second brother with an MI in his 50s. No family history of autoimmune disorder. She does not smoke, drink alcohol, or use illicit drugs. Before 6 months ago, the patient was doing well with no significant problem. But in the last several months, she had been in rehab facility because of severe debility from shortness of breath. And she does not have any allergy. So her review system, she did have dyspnea on exertion PMD orthopnea with cough and clear sputum. She had tightness of the skin of the fingers and face. She had trouble with dysphagia and has been on liquid diet for a period of time now. Generalized weakness, fatigue, and lower extremity edemas. The rest of her review system was otherwise unremarkable, include no fevers, no orthalgia, and no Raynaud phenomenon. On physical exam, she was afebrile. She has an elevated blood pressure, 171/81, and she was 98% on 2 liters nasal cannulas. The patient appeared weak on examination, and she did have bilateral crackles, hypopigmented skin areas, 3+ pedal edema in the lower extremity. The rest of her physical exam was otherwise unremarkable. She did not have any clubbing or cyanosis. And her lab works, hemoglobin is low, 9.6, her creatinine 1.35, and liver function test was within normal limit. The albumin was 2.3, BNP 2100, troponin 0.17, but that did not trend up. P-ANCA and C-ANCA were negative, and she did have a positive ANA. On chest X-ray, she had marked cardiomegaly without pulmonary vasculature congestion. There were bilateral pleural effusion, more on the left than on the right. EKG shows normal sinus rhythm, and I was not given the EKG strip. So I asked for an echocardiogram. To be honest, I don't know how to read echo, so I got this instead. Her ejection fraction was 65%, so it is not systolic heart failures. And the patient did have thickening of the left ventricular wall. Her cardiac index is on the low side, 2.49. So we're going to take a closer look at the diastolic function of this patient. So based on the echocardiogram, the cardiologist can calculate the E to A and the E to E prime ratio, and this can help you assess what the diastolic function would be. In this patient, her value was consistent with pseudo-normal diastolic heart disease, and that is correlated with moderate diastolic dysfunction. So the rest of the echocardiogram report show normal left ventricular internal diameter, mild aortic stenosis, and mitral regurg. She had moderate tricuspid regurg with an RVSP of 80. There's dilation of the atria and the right ventricle. There were low pericardial effusion and no definitive sign of tamponade. So just to kind of take a look at this patient again with her problem list, the patient did have bilateral pleural effusion with possible pulmonary hypertension based on the echo and dyspnea. She had pericardial effusion, lower extremity edema with diastolic left ventricular dysfunction. There were skin thickening of the hands and face, vertigos, and an unknown rheumatologic disorder. The patient has anemia and dysphagia. So because the echocardiogram only show a moderate diastolic dysfunction, I didn't think it was enough to cause her this severe of a symptom, and the symptom did not get better with Lasix. So I'd like to take a look at her pulmonary hypertension. So definition for pulmonary hypertension include a pulmonary artery systolic pressure of more than 35 or a mean pulmonary artery pressure is more than 25 at rest. Some would add another criteria with pulmonary vasculature resistant more than 3 Wood unit, and that would indicate a pulmonary arterial hypertension. And on physical exam, you would see a loud P2, tricuspid and pulmonary regurgitation, murmur with right ventricular S3. There can be left parasternal lift with JVD and right heart failure signs, including lower extremity edemas, liver congestion, and ascites. So during a right heart cath, the catheter is inserted into a large vein and advanced into the right atrium and then into the right ventricle past the pulmonic valve. And on the waveform tracing, when you see the dichotic notch, that indicates that the catheter tip has passed the pulmonic valve. And once you're in the pulmonary artery, the tip of the catheter can be advanced with the balloon inflate until the flow has stopped. And doing this will cause equilibrization of the pressures with the pulmonary capillary, pulmonary vein, and the left atrium. So you're able to measure the pressures in the left atrium. And also during a right heart cath, a response to vasodilator can be done. And this is usually done with a short-acting vasodilator, inhaled nitric oxide. The criteria for vasodilator responsiveness include a mean pulmonary arterial pressures of decreased by 10 or more and decreased to less than 40 with a normal cardiac output. And about 10% of the patient with pulmonary arterial hypertension respond to vasodilators. And in this patient, they can have prolonged survival with long-term treatment of calcium channel blockers. So there are 5 groups of pulmonary hypertension, and I'd like to take a look at each one of them, starting with group 2, because group 1 is the answer. Group 2 is the left heart disease. 78% of the patient with pulmonary hypertension are due to left heart disease. And in this patient, you would have elevated pulmonary capillary wedge pressure more than 15. This can be due to systolic, diastolic, or valvular disease. And so we talk about her left heart disease, and it was not enough to cause her pulmonary hypertension. And group 3 are due to lung disease or hypoxia. This made up of 9.7% of patients with pulmonary hypertension. And this patient did not have COPD, she did not smoke, no wheezing, no history of interstitial lung disease. And on the next slide, we'll talk about her CT scan. Her CT scan did not show interstitial fibrosis. The patient did not have sleep disorders or muscle weakness or chest wall restriction that would suggest alveolar hypoventilation, no exposure to high altitude, as she did not have any developmental abnormality that I was given. So on her CT scan, she did have interstitial septal thickening and scattered ground glass opacity consistent with pulmonary edemas. There were, as we've seen on the X-ray, bilateral pleural effusion and pericardial effusion. So group 4 are due to chronic thromboembolism, and 0.6% of pulmonary hypertension are due to group 4. The patient VQ scan was not suggestive of chronic thromboembolism. And group 5 are due to either unclear or multifactorial. In this patient, she has a CPC that was unremarkable except for anemia, and a SPREP with immunofixation that did not show any M spike, so unlikely to be due to hematologic disease. And on the CT scan, there were no granulomas to suggest sarcoidosis. She did not have any metabolic disorder that we know of, and there were no mass on the CT scan or medial astenitis to suggest this disease. So we rule out the other group. Now I'd like to talk about the group 1. These are due to pulmonary arterial hypertension, increase in the resistance of the small arterioles in the lungs, and this made up of 4.2% of pulmonary hypertension. The pulmonary capillary wedge pressures are less than 15 to rule out left heart disease, and the resistance would be more than 3 Wood units. On this imaging, you see dilation of the pulmonary artery due to pulmonary arterial hypertension, and pruning of the distal vasculature. This might be hard to see up there. And on a VQ scan, you can have a mood-eaten appearance. This can sometimes show up on a chronic thromboembolic condition. So the differential within group 1 include idiopathics, heritable. The patient did not have family history of pulmonary arterial hypertension. And I asked Dr. Moran about all these drugs, and she said the patient, there's no report that the patient was on any of this, and I was not given that she was on any chemotherapy. So within group 1, you can also have connective tissues disease related, includes Crash syndrome, scleroderma, mixed connective tissues. We'll talk about this condition a little bit later. The patient did not have muscle weakness or typical skin finding to suggest dermatomyositis, and she did not have liver disease, myalgia to suggest polyarteritis nodosus. And she has no HIV exposure, no cirrhosis or Budd-Chiari disease to suggest portal hypertension, and no history of congenital heart disease, no exposure to in endemic areas, liver failures or fever to suggest schistosomiasis. And she did not have any evidence of chronic hemolytic anemia. So a systolic sclerosis can have characteristic of vasculopathy, positive antibody to autoimmune, and fibrosis in the tissues. And there are different subgroups, include diffuse, limited. Crash syndrome is part of the limited disease, and systemic sclerosis, since scleroderma without skin involvement. So for scleroderma, there are 2 different ways a patient can get pulmonary hypertension. The first one is pulmonary arterial hypertension, and this is group 1. So the signs and symptoms are indistinguishable from idiopathic arterial pulmonary hypertension. And you can have decreased DLCO with a pretty much normal spirometry and lung volume. They are most commonly associated with the limited scleroderma. The second way is a patient with scleroderma can have interstitial lung disease, and this would cause a group 3 pulmonary hypertension, and that you would have a pulmonary function test that show restrictive disease, and a CT scan that shows scarring fibrosis pattern in the lung. These are called secondary pulmonary hypertension due to lung disease, and this is more commonly associated with the diffuse disease. So we have talked about all the differential for pulmonary hypertension, and I looked at all of them. None of them really fit this patient, maybe except for connective tissues disease. But pulmonary arterial hypertension would not explain the pulmonary edemas and pulmonary pleural effusion in this patient with septal thickening that you see on the CT scan. So what else can this be? Looking at this, I feel like trying to search for the needle in the haze by picking away all the haze and still cannot find the needles. So what else can there be? So there on the Dana Point pulmonary hypertension classification, there is group 1 prime. Group 1 prime is different than the rest of the group and different from group 1, beginning with the name. So 1 prime is an oxymoron. According to these people, 1 is not a prime. So group 1 prime include pulmonary venous occlusive disease, and this was first described in 1934, and many cases are often misclassified as idiopathic pulmonary arterial hypertension. There are extensive diffuse occlusion of the pulmonary vein by fibrosis tissues, and the signs and symptoms are similar to pulmonary artery hypertension. And on physical exam, you would see pleural effusion and pulmonary edemas, like you see in this patient. And if you give the patient a short-acting vasodilators, the patient can go into acute pulmonary edemas and respiratory failures. This is because with a vasodilators, you would cause dilation of the pulmonary artery, and this will cause the blood to flow into the capillary. But this disease has stenosis or occlusion of the pulmonary vein. So you would have increased hydrostatic pressure in the capillary and increased pulmonary edema, pleural effusion. On a CT scan of the lung, you can see lymph node enlargement, centrilobular ground glass opacity, pretty much a sign of pulmonary edema, and septal line thickening. The treatment for this is anticoagulation and a lung transplant, but this disease is very progressive. More often than not, the life expectancy of the patient is shorter than the wait list for a lung transplant. And the annual incidence for this is about 1 to 2 in 10 million. A rare disease is pulmonary capillary hemangiomatosis. It was first described in 1978, and for the first 18 years, there were 18 cases reported. There has since been more cases reported, And these are due to localized, aggressive, benign vascular neoplasm of the lung with proliferation of the thin wall capillary in the lung parenchyma. And 73% of patients with PVOD can have coexisting PCH. You can have hemoptysis in 30% of the patient that is not seen in PVOD. And the alveolar capillaries are engorged and tortuous. CT scan of the chest can show reticulonodular or micronodular patterns with smooth septal line thickening. In most cases, the diagnosis is not made until autopsy. So is group 1 Pham the straw that look like a needles or needle that look like a straw? So can this stand the test? Does it fit the patient? It would explain the pulmonary edemas and pleural effusion, but does not explain dysphagia, her skin condition finding, and this does not explain pericardial effusion. So now I need help. So I emailed Dr. Moran with this exact concern that I have two different differential diagnoses. Neither of them explain what's going on in the patient completely. And of course, the message to Dr. Moran is clear. And so I have to say Dr. Moran is super nice, and she really did give me a lot of help. I don't think I could have gone very far without her help. So I did take her advice and read a little bit more. So the obvious question is, can these two diseases occur together? And a simple search on PubMed for systemic sclerosis and PVOD and CPH shows a couple of articles. I also did this for mixed connective tissues disease, and there were 8 articles for the mixed connective tissues with PVOD, but none associated with PCH. I also searched for undifferentiated connective tissues disease, but there was no result found. So here are all the articles to look at a easier table. So as you can see, most of the patients have limited scleroderma with PVOD. There were a couple of case reports here and there. I know one case there and one case there had claimed that they are the first one to publish a case of that type. So we'll take a closer at that. So this is the first PCH in scleroderma, and this was a limited disease. The second articles report the first PVOD in mixed connective tissues. And in this patient, she had rheumatoid arthritis for 20 years. And then 1 year before her death, the patient developed symptoms of pulmonary arterial hypertension. And she actually passed away from a pulmonary embolism. And on autopsy, they found PVOD. It was unclear in the article if mixed connective tissues and PVOD occurred together, or it was by chance that this patient has both. So if you want to do something nobody have ever done before, look for this case. And if you're wondering if I try to cheat by looking at the demographic for each of this and see if any of them match my patient, I did, but they didn't match. So let's look at the mixed connective tissues disease and the rest of the connective tissues disease and see which one matched my patient. So this recommendation from the American College of Rheumatology is a guideline to diagnose systemic scleroderma. And this coming out next month. There is a version available online. And to make the diagnosis, you must rule out skin condition that looks like sclerodermas, and those are down here. And once you have done that, you calculate the point for the patient, and if the patient has 9 or more points, then she or he would have the diagnosis. In this patient, she had a ANA that was positive and a pulmonary arterial hypertension, but she did not have Raynaud phenomenon, telangiectasia, no fingertip lesions, and she did not have skin thickening proximal to the MCP. There was questionable sclerodactyly. The rheumatologist team has seen the patient and did not think the patient has sclerodactyly. So at this point, she does not have diagnosis of scleroderma. And if you don't have diagnosis of scleroderma, what else could it be? Sometimes this can be classified into the undifferentiated connective tissues disease, and because this does not meet criteria for the other autoimmune disease. So common symptoms include arthritis, arthalgia, Raynaud phenomenon, leukopenia, and there is a proposed criteria. There's no agreed upon guideline to diagnose this because different people has different opinion, but there's one article that has a proposed criteria, and this includes at least one clinical manifestation of connective tissues disease, a positive ANA, and a duration of the disease for at least 3 years. The major organ involvement are unusual, although interstitial lung disease can occasionally be a late complication of the patient, and pulmonary hypertension has not been reported with this disease. So at this point, it's hard to say that this patient had undifferentiated connective tissues disease. So there is another condition, systemic scleroderma, sine scleroderma, and this was first reported by Dr. Rotman in 1962, and in 2000 there is a proposed criteria to make diagnosis. However, there's no guideline to make the diagnosis. So the proposed criteria include absence of skin thickening, Raynaud phenomenon, or a peripheral vascular equilibrium, skin thickening, or digit ulcers. You would have a positive ANA and at least one visceral organ involvement. So in this patient, she did not have Raynaud phenomenon. It is hard to say that the patient has this condition. So what about mixed connective tissues disease? This presents as sequential occurrence of overlapping clinical features, including lupus, polymyositis, rheumatoid arthritis, or systemic sclerosis. And this developed over periods of several years. So initially, you can have some of the symptoms, and over a period of several years, the symptoms start to show up. Not all of them at the same time, and it has a 10-to-1 female predominance. The sign and symptoms include Raynaud phenomenon, swelling of the hand, arthritis, fatigue, pericardial effusion, and trigeminal neuralgia. The lupus antibodies are negative, and 100% of this patient would have anti-U1 RNP. The main cause of death for this patient are pulmonary arterial hypertension, and that that can cause death in 2/3 of the patient that has mixed connective tissues disease. Some rheumatologists does not think mixed connective tissues disease should be a separate disease by itself. It sometimes classified as undifferentiated connective tissues disease. So now, really, none of the connective tissues disease fit my patient exactly, maybe except for mixed connective tissues disease. But even that, without a U1 RNP and progression of the patient to involve other manifestation, it's hard to make the diagnosis. So here is my final answer. Because I am indecisive in nature, the answer would be probable group 1' pulmonary hypertension due to pulmonary venous occlusive disease or pulmonary capillary hemangiomatosis. You cannot make the distinction between these two without tissue biopsy. And in the setting of possible mixed connective tissues disease or undefined connective tissues disease, and the test I would do would be anti-U1 RNP, a right heart cath to confirm pulmonary hypertension, and a lung biopsy. Although the patient that has PVOD and PCH can have increased risk doing a lung biopsy, having a lung biopsy can get the patient to a lung transplant faster. So I've really tried to stick with the objective, but I did not go over the first objective. I just have one slide on that. And here are the possible preventable cause of hypoxia. Looked like the non-rebreather mask was not inflated. So in summary, you should screen for pulmonary hypertension in patients with systemic sclerosis and mixed connective tissues disease, because this tends to have high morbidity and mortality with this patient. And it doesn't matter if you're first or second, as long as you're better than third. And here are my reference. I'm just giving you a couple of seconds to look at them for those trying to count how many of these are written by Dr. Arolagas. Anybody have a count yet? Well, if you say all of the above, you're correct. Dr. Arolaga is the author for all of these articles, and these are just on the topic of pulmonary hypertension. So it's very impressive. And
They're different articles, right?
Yes, sir. They're different. They're not copy and paste.
But they all say the same thing, right?
That's right.
So I have to admit that for some of this article, I actually finished reading them before really realizing who has written it. So I'd like to thank you for all these articles. If you are going to ask me a question about pulmonary hypertension, please take into account that I only have 4 weeks to work on this. And here are my Yes, sir. Oh, sorry. Here are the non-aerologous references. And so I'd like to thank Dr. Marcus, the assistant program directors, Dr. Moran for a wonderful case, Dr. Reddy, as always, for his emotional support, and the chief, thank Lindsay for tolerating all the bad jokes and bad grammar, and Dr. Leva, Spratly, and Barnett for their help on connective tissues disease, right heart cath, and echocardiogram, and the rest of the rheumatology department for their helps, Dr. and Dr. Hodges for his help on the Blue Note. And I'd like to thank Dr. Marcus for agreeing to do the photo for this. So thanks for the Blue Note. I hope I still have a job tomorrow. It might be a mistake trying to make jokes involving the chairman and my program directors. So, Baylor Scott West should not be responsible for what I say up here. So the answer is coming up. You don't want to leave yet. And I think I'm not stay around for a little bit.
All right. Thank you, Joe. Great job. Great job. That was a great presentation. I think you kept us all entertained and on the edge of our seat. We have the medical students will be presenting next. Bethany Rame is representing them, so if you want to come on up here.
Hi, so we met as a class to discuss the case, and we started by reviewing the causes of pulmonary artery hypertension. Our first thought was maybe that this was acute on chronic congestive heart failure given her medical history. However, after looking at the echo, she had a normal ejection fraction, and we felt that her diastolic heart failure was not enough to cause her symptoms. We then looked at thromboembolic disease, but her VQ scan was normal, so we ruled that out. She didn't have any evidence of lung disease, so we ruled that out as a cause as well. Our next thought was scleroderma, so we went through the diagnostic criteria of scleroderma as Dr. Pham did. She met some of the criteria for that. However, there were some major ones that she didn't meet, like the Raynaud's phenomenon. However, she had a lot of systemic manifestations associated with scleroderma, like dysphagia, the pericardial effusion, hypertension, and the skin tightening of the hands and face. So we felt like we couldn't definitively rule that out. However, she declined so quickly that we felt like we had to look at other causes as well. So our final diagnosis was also pulmonary veno-occlusive disease, likely related to a mixed connective tissue disorder. We felt like we still couldn't rule out pulmonary capillary hemangiomatosis. However, it's a very rare disease, so we felt like pulmonary veno-occlusive disease was the more likely diagnosis.
Thank you very much. That's a great summary as well right there. So next we have from pathology, Amelia Sabenga, who's going to talk to us about the findings that she has.
Okay. Drum roll. I'm Amelia Saibenga. I am a first-year pathology resident. This case was kind of tough and interesting. We received biopsy from heart, lungs, and pericardium. So just for review real quick, normal lung. This is our patient's lung. Here you can see this arterial thickening, and we've got some increased cells in the alveolar spaces. This is an elastin stain, and the elastin is showing deposition of elastin in the media of veins, and we also have this arterial hypertrophy. So this is actually good for diagnosis of both veno-occlusive disease and pulmonary hypertension. Normal alveoli, increased cells. These are hemosiderin macrophages. They've eaten up red blood cells. You can see the hemosiderin on an iron stain here. These are also called heart failure cells. And they're typically seen in pulmonary edema, but they can also be seen in veno-occlusive disease. Normal myocardium, and this is the heart biopsy. These cells are huge. Normal, not normal. Normal, not normal. The pericardium was completely normal, so I didn't put pictures of it because it wasn't that interesting. Let's see. So this is actually pictures of the autopsy heart. And here we're actually seeing this patchy scarring fibrosis in the myocardium. And then we also, that would be here. And then here we've got more of this arteriolosclerosis. And here. And this is all fibrous tissue. We found it at different stages of development or ages, suggesting acute and chronic ischemic insults. So this had been going on for a while. This is a younger infarct, but still you can see the vessel hypertrophy here and here, and the macrophages here kind of indicate that this is of a younger age. It's also kind of fluffy instead of scarred down. Normal skin. We found here, this is the patient's skin. It's a little bit dense. Normal, not quite so normal. And a little closer view, we kind of see some fibrosis here. And we also have some plasma cell and lymphocytic inflammatory infiltrate in the subcutaneous region, which is kind of consistent with scleroderma. But these are really subtle changes, just like the changes in the lungs were very subtle. And that, it's not really enough to call scleroderma. Normal kidney, happy, fluffy, glomerulus. This is severe arteriolosclerosis in the kidney. You can just see this huge thickening, this intimal hypertrophy in these smaller vessels, and some fibrosis. Same thing, and then we have some sclerosed glomeruli and some focal hypertrophy. Normal esophagus. The patient had been complaining of some dysphagia, and we did find some fibrosis in the esophagus. We also found some hyperplastic nerve tissue in here, and these are all kind of suggestive more of a trauma or maybe a hiatal hernia. And so this may actually have been the cause of the patient's dysphagia and may not have been related to a connective tissue disease. Her labs, she was a little anemic. She had a hypergammaglobulinemia. She had this positive ANA. And in terms of scleroderma, she had a negative SEL70 and a negative centromere. So is it scleroderma? Is it mixed connective tissue? Pretty comfortable with calling it a connective tissue disease. The pulmonary and GI findings can occur in both scleroderma and mixed connective tissue. Heart failure and long-standing hypertension can cause some of these arterial changes as well. The cardiac involvement in mixed connective tissue typically involves the pericardium, which was normal, and causes right atrial hypertrophy, leading to arrhythmias, whereas scleroderma has the patchy myocardial fibrosis that we saw. Hypergammaglobulinemia is more common in mixed connective tissue disorder, but it also occurs in scleroderma when there is renal involvement. The negative serology doesn't necessarily mean a whole lot because we only did 2 of 9 tests, and these tests are on average positive about 25% of the time. So the sclerodactyly wasn't mentioned on autopsy either, but the patient had a massive anasarca, and that may have obscured any findings of sclerodactyly, and we did not do a biopsy of the fingers. So based purely on histology, given all of the findings, especially given the cardiac, the renal, and the skin findings, as subtle as they may be, scleroderma is actually a more likely diagnosis on a histopathologic perspective. However, it's not definitive, and mixed connective tissue cannot be ruled out based on the available information. That's it.
All right, thank you. And to kind of finish things out and give us the final points on the case, we have Dr. Jennifer Moran, who's one of our hospitalists.
All right. Okay, so in the interest of time, I'm probably going to truncate my presentation just a little bit. But I wanted to start by congratulating Dr. Pham on just a wonderful job. I think he had his hands full. Not only did we present him with a very rare disease, we presented it in the context of a patient whose clinical presentation wasn't exactly cut and dry. Obviously, even with the pathologic findings, we can't even consistently determine if it was really scleroderma, or if it was mixed connective tissue disease, or if it was some other entity in between. And so Dr. Pham actually dealt with those incongruities very well and was very persistent in trying to make the most out of a difficult case. So he should be congratulated for that. So just to kind of give you a short progression of how things went. So the initial presentation was decompensated heart failure. She had elevated RVSP, bilateral lower extremity edema, all the signs of right heart failure. And then we had this unusual skin findings, concerns with dysphagia, pulmonary hypertension, at least suggested by the echocardiogram, obviously not a definitive diagnosis, and then the pericardial effusion. So within a week's time, Dr. Pham presented and said, scleroderma with pulmonary hypertension plus or minus idiopathic. And at this point in time, I was thinking, we had looked at this patient for a month, and in a week's time, he's going to have the diagnosis. I figured it was only seconds until he managed to proceed and kind of come up with PVOD. So I was almost a little disappointed. I was like, my goodness, not enough of a challenge. And then we gave him that the SCL70 was negative, which kind of threw him back to the drawing board. So I think it was good because he did quite a bit more reading and learning, and that's kind of what the process is. And I'm sure that he would have liked to have been back at Dana Point, California, where the classification system for pulmonary hypertension was made back in 2008. And so what he did after he got that SCL70 antibody negativity was go back and just go systematically through the different classification groups to determine where he should proceed. And he did a great job, and I think he walked us through it very nicely. Just to give you a little bit of background, obviously, to complete the presentation, it would have been very helpful for us to have had a right heart cath and completed some of the antibody testing. And we would have very happily have done that. But our patient, unfortunately, had a very truncated stay with us. We had the opportunity to get her CAT scan, which again didn't show any evidence of pulmonary parenchymal disease. It did show the findings of the ground glass and the lobular thickening, but no evidence of parenchymal disease either related to scleroderma or related to findings consistent with COPD. And thereafter, we proceeded with a VQ scan, and that was negative for any abnormalities there. The plan was then to proceed with a right and heart cath, and she actually went down to the cath lab, and we had a code at that time. So that's why our evaluation thereafter stopped. At the time of the code, we had an echocardiogram probe on her chest, and we actually saw an embolus float into the pulmonary vascular system, and so she went emergently to surgery, which is how we ended up getting the lung tissue and biopsy. And unfortunately, given her longstanding pulmonary hypertension, she did not do well post-surgically. And then she had the post-mortem autopsy that kind of filled out the picture for us. So again, Dr. Pham did very well with kind of the limited information we had. He had to kind of make a leap of faith that the abnormalities that we saw on the echocardiogram were actually indicative of right heart or pulmonary arterial hypertension. So he did come to the right conclusion based upon the tissue diagnosis that we had initially was pulmonary veno-occlusive disease. And then I think he did very well with kind of sorting through and determining did this patient truly have a diagnosis of scleroderma to go along with it, or was it a mixed connective tissue disease? And obviously, even with the pathology, we're still kind of sorting through. But again, I think it was a very interesting presentation of a very interesting case, and I commend him on his evaluation. Again, I think in the interest of time, we'll go ahead and I thank you all very much for your support of Dr. Pham.
Thanks so much, and thanks, Dr. Moran. And if you have any questions, feel free to come up and talk to Dr. Pham. I'm sure he'd be happy to talk to you.